Assalamu alaikum. This lecture is about diverticular disease, and here just to quick reminder about the terminology. Diverticular disease is the presence of symptomatic diverticuli. Diverticulosis is diverticuli without inflammation. Diverticulitis is inflammation and infection of the diverticuli. False diverticulum is the presence of herniated mucosa and muscular mucosa through the bowel wall, and usually is acquired. True diverticulum is compromised of all layers of the bowel wall and usually is congenital. Epidemiology: most colonic diverticuli are false and usually occur between the teniae coli at points where the blood supply penetrates the colonic wall. So these are inherited defects through which the mucosa, submucosa will herniate. Usually is thought to be due to bulging due to the high pressure inside the lumen. Diverticulosis is common in the Western countries, and sigmoid colon is the commonest site to be affected. Nowadays we are seeing more and more cases of diverticular disease in the Jordanian population due to westernization of our diet and habits. And here just to illustrate the diverticular disease and its pathology inside the bowel wall. Etiology is poorly understood, but the most acceptable theory is the lack of dietary fiber. So there is not enough fiber, and that will result in reducing the stool volume, and that will lead to high intraluminal pressure and increase the tension inside the bowel lumen, causing the herniation of the mucosa and the submucosa. And the chronic contraction will cause muscular hypertrophy and bulging diverticuli. High fiber diet decreases its incidence. Most of the cases are asymptomatic. And here in this diagram we'll show you the different pathological representation. Here you can see that there is inflammation or diverticulitis when there is a perforation and escape of feces or fecal fluid. So this is perforation. If you remember, these diverticuli happen through inherited defect in the bowel wall, where blood vessels enter the bowel wall. So the blood vessel here could be injured, and that will result in bleeding. When there is hypertrophy, hypertrophy of the muscle, this can lead to stenosis and bowel obstruction. If the perforation is not sealed, there will be extensive inflammation and abscess formation. So acute diverticulitis occurs in about 10 to 25% of patients with diverticular disease, peridiverticular and pericolic infection with macroscopic or microscopic perforation also can result. The spectrum of disease range from mild to quite extensive and severe diffuse peritonitis. Usually when there is diverticulitis, patient will present commonly with left-sided abdominal pain, with or without fever. Mass could be felt. They will have leukocytosis. Abdominal X-ray may show free air in the peritoneal cavity. CT scan also may show pericolic inflammation, phlegmon or abscess formation. Contrast enemas, barium should be avoided. Colonoscopy also are not indicated as it could exacerbate the condition. People with uncomplicated diverticulitis can be treated conservatively in most of the cases with broad-spectrum antibiotic and low residue diet, and they can be managed as an outpatient. People with severe presentation, they need admission to the hospital and they require intravenous antibiotics. If the patient fails to respond to the conservative management, you need to think about a complication such as abscess formation, and most of the time, luckily, these can be drained percutaneously via image-guided drainage. Now, people who have recurrent diverticulitis, you need to think about elective sigmoid resection. If it was in very young or people who suffer from immunosuppressed disease condition, then you need to think about doing elective sigmoid resection even after the first episode. Once you successfully treat an episode of acute diverticulitis, after about 4 to 6 weeks, you need to do for those patients preferably colonoscopy or at least sigmoidoscopy, and that is to exclude malignancy coexisting with diverticular disease. The other presentation of diverticular disease is abscess, formation, obstruction, peritonitis with a free perforation, fistula between the colon and the adjacent structures, such as the bladder, vagina, or small bowel. And in this slide, it shows the Hinchey classification of diverticulitis with diverticular perforation. So in class 1, there is localized pericolic abscess formation. Here is a large mesenteric abscess formation, and here there is a free spillage inside the peritoneal cavity. It is no more localized, and here you can see fecal contamination of the peritoneal cavity. So that's Hinchey class 4. The importance of Hinchey classification, it will guide your treatment and therapy. People with abscess, we said that percutaneous drainage is very helpful. If it is not feasible or the patient condition does not improve, then you need to think about doing laparotomy with or without sigmoid dissection. Obstruction happens in about 2/3 of the patient, and complete obstruction in 1/10 of patient. Most of the time, the obstruction can be treated conservatively, and the people who do not respond to conservative management, they need surgical intervention. Fistula happen in about 5% of patient, and the fistula should be evaluated by imaging and colonoscopy, A, to evaluate its anatomy, and B, to exclude other disease conditions such as cancer or inflammatory bowel disease such as Crohn's. The treatment is usually surgical by resection of the affected segment and repair of the secondarily affected organs such as small bowel or bladder or vagina. Hemorrhage again could happen from diverticular disease on occasion can be massive. Most of the time the bleeding will stop spontaneously without any intervention. To localize the site of the bleeding, you could utilize colonoscopy or angiography. Again, most of the time the bleeding can be managed conservatively, but if the patient is massive or persists or recurs, laparotomy and segmental colectomy may be required, and occasions you might do subtotal colectomy to salvage patient life. Giant colonic diverticuli is extremely rare condition, and the diverticulum is usually on the antemesenteric border of the sigmoid. Commonly is asymptomatic, but it might cause vague abdominal pain. Complications include perforation, obstruction, or volvulus. Barium enema is diagnostic, and resection of the affected part of the bowel is curative. Right-sided diverticulum affecting the cecum and the ascending colon, and usually occurs in young population. Commonly is asymptomatic, and if there is a single large diverticulum causing inflammation, diverticulectomy is the procedure of choice, but occasionally you might have to do limited right hemicolectomy. Hemorrhage can occur, and the principle of treating right-sided hemorrhage or right-sided hemorrhage from diverticulum is as left-sided diverticular hemorrhage. Meckel's diverticulum is probably the most common congenital anomaly of the GI tract, affecting 2% of the population. It has a ratio of 3:2 in males. It is a true diverticulum and is usually located about 2 feet from the ileocecal valve. 60% of Meckel's diverticulum contains heterotopic mucosa, either gastric or pancreatic tissue. The Meckel's diverticulum is a result of failure of obliteration of vitelline duct, and the complications of Meckel's diverticulum common is bleeding and is the result of ileal mucosa ulceration due to the adjacent gastric heterotopic gastric mucosa found in the Meckel's diverticulum, producing acid and causing ulceration of the nearby ileal tissue. Second complication is obstruction, either due to volvulus or due to the presence of a band intussusception or stricture secondary to chronic inflammation and diverticulitis. Clinically, most of the time they are asymptomatic. Sometimes they present with complication. The commonest presentation, if symptoms are going to arise, are bleeding, obstruction, and diverticulitis. And bleeding is the commonest or most common presentation in children younger than 18 years old. Bleeding becomes less common or rare after the age of 30. Intestinal obstruction is the commonest presentation in adults. Diverticulitis could happen in 20% of patients with symptomatic diverticular disease. Diagnosis: most are discovered incidentally during imaging, endoscopy, or surgery. Radionuclide scan, technetium scan suggests its presence when there is heterotopic ectopic gastric mucosa. Angiography can localize the site of the bleeding and suggest its presence. Treatment for diverticulitis: they need diverticulectomy. Bleeding, you have to do segmental ileal resection to include the diverticulum along with the ulceration and the bleeding from the nearby terminal ileum. Also, segmental ileal resection is indicated when there is tumor in the diverticulum. Now, management of incidental asymptomatic Meckel's diverticulum is controversial.